Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 242 of our pharmacotherapy series, which majors in endocarditis. The first question reads, GBS, a 35-year-old woman, has been complaining of anorexia, weight loss, and fever for the past 2 months. Her medical history is significant for an aortic aneurysm with insufficiency that resulted in an aortic valve replacement porcine 3 years before admission. Approximately 2 months before admission, GBS had a caesarean section followed by a tubal ligation. She did not receive antibiotic prophylaxis for either procedure. Physical examination revealed a thin woman, 5 foot 0 inches, weighing 48 kilograms, in no acute distress with evidence of a systolic heart murmur, splinter hemorrhages, and petechiae on her soft palate. Her temperature was 100.2 degrees Fahrenheit. Her WBC count was 14,000 per microliter. The SI units are 14 × 10 per liter, with a slight left shift. All other laboratory results were within normal limits. She was not taking any medications, and she has a documented allergy to penicillin, rash, urticaria, and wheezing. The working clinical diagnosis was probable bacterial endocarditis, which was confirmed when 4 sets of blood cultures grew gram-positive cocci. Antibiotic therapy with gentamicin, dosed at 50 mg IV every 8 hours, and vancomycin, dosed at 1000 mg IV every 12 hours was begun. Biochemical testing subsequently identified the organism as Enterococcus faecalis, highly resistant to streptomycin, with an MIC above 2000 micrograms per milliliter. So my question to you is, why were 2 antibiotics prescribed for the treatment of enterococcal endocarditis in GBS? Enterococci, unlike streptococci, are inhibited but not killed by penicillin or vancomycin alone. The synergistic combination of penicillin or ampicillin, piperacillin, or vancomycin with an aminoglycoside is required to produce the desired bactericidal effect. One definition of synergy is when a combination of antibiotics lowers the MIC to at least 1/4 the MIC of either drug alone. The mechanism of synergy against enterococci is explained by an increased cellular uptake of the aminoglycoside with agents that inhibit cell wall synthesis, e.g., beta-lactams and vancomycin. Because GBS is allergic to penicillin, vancomycin was prescribed with an aminoglycoside. Relapse rates are unacceptably high if penicillin is used alone for the treatment of enterococcal endocarditis. Numerous in vivo and clinical studies have confirmed the in vitro synergy for penicillin in combination with streptomycin or gentamicin for enterococcal endocarditis. Streptomycin resistance. As many as 55% of all enterococcal blood isolates are highly resistant to streptomycin, with an MIC above 2000 micrograms per milliliter, and the combination of streptomycin with penicillin is not synergistic for those isolates. In contrast, gentamicin in combination with penicillin, ampicillin, or vancomycin is synergistic for most blood isolates of enterococci, regardless of their susceptibility to streptomycin. In addition, ototoxicity in the form of vestibular dysfunction secondary to streptomycin therapy occurs in nearly 30% of patients in the treatment of enterococcal endocarditis and is most often irreversible. High peak concentrations and prolonged drug therapy have been associated with ototoxicity, but laboratory assays for streptomycin levels are not readily available. For these reasons, gentamicin in combination with penicillin or ampicillin or vancomycin is recommended by most authorities for the treatment of aminoglycoside susceptible and, in particular, streptomycin-resistant enterococcal endocarditis. As it was for GBS of note, other aminoglycosides cannot be used to substitute for gentamicin or streptomycin because of the uncertain correlation between in vitro synergy and in vivo efficacy. Next we will discuss gentamicin resistance. Of the aminoglycosides, gentamicin and streptomycin are often tested with penicillin or ampicillin for synergistic bactericidal activity. About 10% to 25% of the clinical isolates of Enterococcus faecalis and up to 50% of Enterococcus faecium are resistant to gentamicin. Without conclusive data, some groups favor long-term 8 to 12 weeks therapy with high-dose penicillin 18 to 30 million units per day IV in 6 divided doses, or ampicillin 2 to 3 grams IV every 4 hours for treatment of resistant enterococci. Ampicillin plus the beta-lactamase inhibitor sulbactam, marketed as Unisin, would be substituted for beta-lactamase producing, high-level gentamicin-resistant enterococci. In light of the increasing prevalence of enterococci with high-level aminoglycoside resistance, the potential synergistic interaction between ampicillin or amoxicillin and a third-generation cephalosporin was explored in vitro and in experimental models of infective endocarditis. A bactericidal synergistic effect was shown between amoxicillin and cefotaxime against 50 strains of Enterococcus faecalis. Amoxicillin MIC decreased from 0.25 to 1 microgram per milliliter to 0.01 to 0.25 micrograms per milliliter for 48 of 50 strains tested. Additionally, Brandt and colleagues demonstrated a synergistic bactericidal effect for amoxicillin in combination with imipenem against vancomycin aminoglycoside-resistant Enterococcus faecium strains. The authors speculated that saturation of different penicillin-binding proteins by different beta-lactam agents may be the underlying mechanism for the synergy observed. In an observational, non-randomized multi-center study, 159 patients were treated with ampicillin, dosed at 2 grams IV every 4 hours, and ceftriaxone, dosed at 2 grams IV every 12 hours, and 87 were treated with ampicillin and gentamicin. There were no differences in mortality, while on antibiotics and at 3-month follow-up, treatment failure, and relapses. The 2015 AHA guidelines recommend double beta-lactam therapy with ampicillin and ceftriaxone as a reasonable option for infections caused by aminoglycoside-resistant Enterococcus faecalis strains. The next question reads, what is the optimal dosage of gentamicin for GBS? Because patients with enterococcal endocarditis require prolonged therapy with aminoglycosides, the optimal serum concentration should minimize toxicity without jeopardizing clinical cure. Early in vitro data indicated that the bactericidal activity of gentamicin against enterococci was not significantly different between peak concentrations of 5 and 3 mg per liter. However, the differences between 3 and 1 microgram per milliliter were significant. Animal models of endocarditis show discordant results in bacterial counts per gram of vegetation in animals on low dose versus high dose aminoglycosides. In experimental endocarditis, multiple daily dosing is more effective than single daily dosing in reducing bacterial titers in vegetations. In contrast, viridin streptococci endocarditis can be managed with single daily dosing. Thus, extended interval dosing of aminoglycosides cannot be recommended for the treatment of enterococcal endocarditis at this time. The only study comparing high dose, that is more than 3 mg per kilogram per day, and low dose, that is less than 3 mg per kilogram per day, gentamicin with penicillin in humans with enterococcal endocarditis evaluated 56 patients during a 12-year period, 36 with streptomycin susceptible and 20 with streptomycin resistant infections. The relapse rate of patients infected with streptomycin-resistant organisms N=20 was not significantly different between the high and low-dose treatment groups N=10 each. Furthermore, patients who received the higher doses of gentamicin experienced a greater prevalence of nephrotoxicity 10 of 10 versus 2 of 10, with a p-value less than 0.001. Mean peak and trough concentrations of gentamicin in patients who received the high doses were 5 and 2.1 micrograms per milliliter, respectively. Corresponding levels for patients receiving the low-dose regimen were 3.1 and 1 microgram per milliliter. Given the available data, it would be reasonable to start GBS on a gentamicin dosage of 1 mg per kilogram every 8 hours, assuming her renal function is normal, and to maintain peak concentrations of 3 to 5 micrograms per milliliter and trough concentrations of less than 1 microgram per milliliter. The next two questions read, why was vancomycin used in combination with gentamicin in GBS? Is this combination effective against enterococci? GBS has a history of penicillin allergy. Most clinicians favor a combination of vancomycin and gentamicin for penicillin-allergic patients with enterococcal endocarditis, although vancomycin plus streptomycin is a suitable alternative. The combination of vancomycin and gentamicin demonstrates bactericidal synergy for about 95% of enterococci strains. In contrast, the vancomycin and streptomycin combination demonstrates bactericidal synergy for about 65% of enterococci. Because GBS has PVE, she should receive approximately 30 mg per kilogram per day, or roughly 1.5 grams per day, 750 mg every 12 hours, of vancomycin in combination with gentamicin dosed at 3 mg per kilogram per day. Serum levels of vancomycin and gentamicin should be monitored as previously discussed. The next question reads, for how long should GBS be treated? Historically, enterococcal endocarditis has been treated with penicillin plus an aminoglycoside for 6 weeks. The overall cure rate with this regimen is about 85%. 4 weeks of therapy is probably adequate for most patients with enterococcal endocarditis. One study evaluated the efficacy of a treatment regimen involving shorter course aminoglycoside therapy, median of 15 days, in combination with a cell wall active agent for a median of 42 days in patients with PVE and native valve enterococcal endocarditis. Clinical cure was observed in 75 of 93, that is 81% patients overall, 78% of patients with PVE, and 82% of patients with native valves. Among those who had a clinical cure, 52% received a beta-lactam, 12% received vancomycin, and 36% received a combination of both. Ampicillin was given in 88% of patients receiving a beta-lactam. The causative organism was Enterococcus faecalis in 78 patients and Enterococcus faecium in 5 patients. Clinical success was also achieved in all 8 patients with native valve infective endocarditis who received either vancomycin 50%, ampicillin 25%, or combination of both 25% without synergistic aminoglycoside therapy. Patients with complicated courses should receive 6 weeks of therapy, including patients infected with streptomycin-resistant organisms, such as GBS, those who have had symptoms for more than 3 months before the initiation of antibiotics, and patients with PVE, such as GBS. Some clinicians recommend 6 weeks of therapy for all patients in whom the duration of illness cannot be firmly established. This accounts for many patients who present with subacute disease. The next 2 questions read: how do enterococci develop resistance to vancomycin? What are the therapeutic implications if GBS is infected with glycopeptide-resistant enterococci? I will briefly discuss glycopeptide resistance in enterococci. Vancomycin-resistant enterococci, abbreviated as VRE, particularly Enterococcus fischum, have emerged in the United States since 1987. The increased use of vancomycin since the mid-1980s has coincided with the increased resistance to this class of compounds. Between 1989 and 1993, the percentage of nosocomial enterococci reported as resistant to vancomycin in the United States rose more than 20-fold, from 0.3% to 7.9%. Enterococcal isolates from intensive care units increased even more dramatically, from 0.4% to 13.6% during that time. Data from the Centers for Disease Control and Prevention National Nosocomial Infections Surveillance, abbreviated as NNIS, system indicate that the rate of increase has slowed down from 31% in 2000 to 12% in 2003. A 12% increase was found in VRE infections in intensive care units between 2003 and the prior 5-year period 1998 to 2002. Nonetheless, epidemiologic studies conducted by the NNIS system, as well as others, have shown that VRE bacteremia is associated with significantly increased morbidity and mortality. Although Enterococcus faecalis is responsible for 80% to 90% of infections caused by enterococci, Enterococcus fischum is more likely to exhibit resistance to glycopeptides compared with Enterococcus faecalis. More than 95% of VRE recovered in the United States are Enterococcus fischum. Glycopeptide-resistant enterococci synthesize abnormal peptidoglycan precursors that lower the binding affinity of glycopeptides to peptidoglycans. VRE can be broadly classified into 3 separate phenotypes A, B, and C, based on 3 structurally different genes and gene products, e.g., altered lagases. Most, approximately 70%, of resistant enterococci are of the VAN-A phenotype, which are resistant to high levels of vancomycin (MIC) above 256 micrograms per milliliter. Expression of resistance is inducible, usually plasmid-mediated, and transferable to other organisms via conjugation. The VAN-B strains exhibit moderate vancomycin resistance (MIC 16 to 64 micrograms per milliliter), and the VAN-C strains are the least resistant vancomycin (MIC 8 to 16 micrograms per milliliter) because of chromosomal-mediated constitutive expression, i.e., not inducible as a VAN-A, and VAN-B. However, VAN-C isolates usually are associated with the much less common Enterococcus gallinarum and Enterococcus caselli-flavus infections. Vancomycin, and also extended-spectrum cephalosporins and drugs with potent anti-anaerobic activity are risk factors for VRE. Few therapeutic alternatives exist for VRE, and synergistic combinations are required for bactericidal activity and clinical cure in endocarditis. Consequently, the treatment of choice is unknown. As a result, practitioners must make decisions using the available data from in vitro synergy studies, experimental models of endocarditis, and scattered case reports. Of additional concern, glycopeptide-resistant isolates often exhibit concomitant high-level resistance to aminoglycosides and beta-lactams, e.g., ampicillin, and penicillin, secondary to either beta-lactamase production or alteration in the target penicillin-binding proteins. Several antibiotic combinations appear promising in vitro and in preliminary animal models of endocarditis, but few data are currently available in humans. Those combinations include high-dose ampicillin, that is 20 grams per day, or ampicillin, sulbactam plus an aminoglycoside, vancomycin, penicillin or ceftriaxone, and gentamicin, ampicillin and imipenem C. listatin, ciprofloxacin and ampicillin, and ciprofloxacin, rifampin, and gentamicin. Streptogrammin and oxazolidinone quinupristin, dalfopristin, marketed as Sinusid, and linezolid, marketed as Zyvox, are two agents with activity and proven efficacy against some infections caused by VRE. Quinupristin, dalfopristin received accelerated approval by the FDA in late 1999 specifically for the treatment of vancomycin-resistant Enterococcus fischum bacteremia. However, in 2010, with other therapies available for the treatment of VRE, this FDA-labeled indication was removed. The fixed product is generally bactericidal against susceptible streptococci and staphylococci, including methicillin-resistant strains, but it is bacteriostatic against Enterococcus fischum. Specifically, Enterococcus faecalis is not susceptible to the agent because of the presence of an efflux pump conferring resistance to dalfopristin. Linezolid has bacteriostatic activity against enterococci, including vancomycin-resistant Enterococcus fischum and Enterococcus faecalis. It is also active against other gram-positive cocci, including Streptococcus pneumoniae and methicillin-resistant staphylococci. Vancomycin-resistant Enterococcus fischum isolates resistant to linezolid have been isolated. Treatment experience with linezolid under the compassionate use protocol reported clinical and microbiologic cure rates of 50% at 6-month follow-up for patients with endocarditis. Vancomycin-resistant Enterococcus fischum was the causative organism for 19 of the 32 patients treated. Common adverse effects associated with linezolid include nausea, headache, diarrhea, rash, and altered taste. Of greater concern is its potential to cause myelosuppression. Thrombocytopenia, leukopenia, anemia, and pancytopenia have all been reported. Up to 30% of patients treated experience thrombocytopenia. Next we will look at daptomycin. Daptomycin is active against enterococci in vitro, with a MIC range of 0.25 to 4 micrograms per milliliter and MIC 90 of 4 micrograms per milliliter for vancomycin-resistant Enterococcus fischum isolates from the United States. For 40 vancomycin-resistant Enterococcus faecalis isolates, the MIC range is 0.015 to 2 micrograms per milliliter, with a MIC 90 of 2 micrograms per milliliter. Of concern is the emergence of daptomycin resistance during therapy for VRE infections. In a case report of a patient with vancomycin-resistant Enterococcus fischum pyelonephritis, the initial isolate had an MIC of 2 micrograms per milliliter. However, after 17 days of treatment, a blood culture yielded growth of vancomycin-resistant Enterococcus fischum with an MIC increased to 32 micrograms per milliliter. Clinical experience with daptomycin for vancomycin-resistant Enterococcus fischum endocarditis is limited, and treatment failure has been reported. If daptomycin therapy is chosen, a dose of 10 to 12 mg per kilogram per day is recommended. The next question reads, BCG, a 35-year-old male heroin addict, was admitted to the hospital with chief complaints of pleuritic chest pain and dyspnea on exertion. Physical examination revealed a cachectic man with a temperature of 104 degrees Fahrenheit, a diastolic regurgitant heart murmur heard loudest during inspiration, splenomegaly, and pharyngeal petechiae. Fundoscopic examination was non-contributory. On the chest radiograph, several pulmonary infiltrates with cavitation were evident. UA was significant for microscopic hematuria and RBC casts. ATEE demonstrated vegetations on both the tricuspid and aortic heart valves. BCG had evidence of moderate heart failure, although his hemodynamic status at that time was stable. 6 sets of blood cultures were drawn over the course of 2 days, and broad-spectrum empiric coverage consisting of vancomycin, gentamicin, and ceftazidime was initiated. 2 days later, 2 of the cultures grew Candida albicans, and a diagnosis of fungal endocarditis was established. So my question to you is, what is BCG's prognosis, and how should his fungal endocarditis be treated? Fungal endocarditis is a rare but life-threatening infection that is difficult to diagnose and even more difficult to treat. Most cases are caused by Candida and Aspergillus species. Fungal endocarditis occurs primarily in IV drug users, patients with prosthetic heart valves, immunocompromised patients, those with IV catheters, or patients receiving broad-spectrum antibiotics. Management of fungal endocarditis generally requires early valve replacement and aggressive fungicidal therapy with amphotericin deoxycholate B 0.6 to 1 mg per kilogram per day with or without 5-flucytosine, 5-FC, dosed at 25 mg per kilogram orally 4 times daily. If BCG had poor renal function, liposomal formulations of amphotericin B dosed at 3 to 5 mg per kilogram daily can be used as an alternative. These antifungal agents should be prescribed for BCG, and his broad-spectrum antibiotic should be discontinued. BCG's clinical presentation and chest radiograph indicate that fragments of vegetation have already embolized to his lungs and possibly to other vital organs, e.g., spleen, and kidneys. Because of the morbidity and mortality associated with major emboli and valvular insufficiency, BCG should undergo surgery within 48 to 72 hours after antifungal therapy has been initiated. The prognosis for BCG is dismal even with proper medical and surgical treatment. In a series analyzing 270 cases of fungal infective endocarditis occurring during a 30-year period, mortality for those who received combined medical and surgical management was 45%, compared with 64% for those who received antifungal therapy alone. Despite initial response to treatment, the rate of relapse is high, that is 30% to 40%, and relapse can occur up to 9 years after the initial episode of infection. Most deaths in IV drug users with endocarditis are secondary to heart failure, a finding already evident in BCG. In addition, replacement of a heart valve for fungal endocarditis in a heroin addict carries a significant risk of late morbidity and mortality. The next question reads, why is it important to treat BCG's fungal endocarditis with the combination of 5-flucytosine and conventional or lipid-based amphotericin B? What is the optimal duration of therapy? The poor prognosis associated with fungal endocarditis warrants the administration of 5-flucytosine in combination with amphotericin B, despite its potential for causing bone marrow suppression and hepatotoxicity. The vegetations from BCG's tricuspid or aortic heart valves already have broken off and caused pulmonary cavitation and possibly splenomegaly. His clinical presentation is consistent with a potentially fatal outcome, therefore, his blood isolates should be tested for in vitro susceptibility to amphotericin, 5-flucytosine, and azoles. Fungi resistant to 5-flucytosine alone may still be susceptible to the synergistic effect of the 5-flucytosine amphotericin B combination. If the organism is resistant to 5-flucytosine, in vitro synergy between these two antifungals should be performed or therapy with an echinocandin should be considered. The optimal dose and duration of antifungal therapy for fungal endocarditis have not been determined by clinical studies. However, postoperative treatment with amphotericin B and 5-flucytosine, if it has in vitro activity, for a minimum of 6 weeks, total dose 1.5 to 3 grams of amphotericin B is recommended and is supported by the poor penetration of amphotericin B into heart valve tissue. In patients with fungal PVE, some experts advocate secondary prophylaxis for a minimum of 2 years or lifelong suppressive treatment with an oral antifungal agent for non-surgical candidates in light of the high rates of relapse. Nephrotoxicity caused by amphotericin B is often a serious dose-limiting factor to completion of therapy, particularly in patients who require a prolonged treatment course. Renal dysfunction secondary to the conventional formulation of amphotericin B may stabilize or improve with the switch to lipid-formulated amphotericin B products, i.e., Abelsit, or Ambisome. The efficacy of the new formulations in the treatment of endocarditis has been demonstrated only in anecdotal reports. Alternative antifungal agents, including echinocandins and azoles, are potential options in patients who experience significant renal toxicities. The next question reads, if BCG experiences significant toxicities because of prolonged combination treatment with amphotericin B and 5-flucytosine, what alternative antifungal agent or agents can be used to treat his fungal endocarditis? Fluconazole, marketed as diflucan, is a triazole compound active against Candida species, particularly Candida albicans and Candida parasilosis. It also has a favorable toxicity profile compared with amphotericin and 5-flucytosine. Successful experience with fluconazole treatment of fungal endocarditis in humans has been described in only a few case reports. Patients with various Candida species were treated with 200 to 600 mg of fluconazole daily for 45 days to 6 months or until death. Fluconazole therapy reduced or completely removed all cardiac vegetations and resolved clinical symptoms. Because of the lack of adequate clinical experience, however, the use of fluconazole in treating fungal endocarditis cannot be advocated except in patients who require lifelong therapy because of the following situations. A. The patient is a poor surgical candidate. B. The patient has relapsed at least once since the initial infection episode, or C. The patient has PVE. Another alternative treatment option is the echinocandins, which are fungicidal against most Candida species, including those in biofilms. A limited but growing body of literature, primarily in case reports, describes the successful outcomes with use of the echinocandins in Candida infective endocarditis. Echinocandin-based regimens including caspofungin, micafungin, and anadulafungin were found to be as effective and to have similar mortality rate as amphotericin-based therapies based on a subgroup analysis of 25 patients in a prospective international cohort of patients with Candida infective endocarditis. 14 months after completing his course of antifungal therapy, BCG was readmitted to the hospital with a 48-hour history of fever, shaking chills, rigors, and night sweats. His vital signs at that time were blood pressure of 100 systolic 60 diastolic, pulse of 120 beats per minute, a respiratory rate of 24 breaths per minute, and a temperature of 103.7 degrees Fahrenheit. A new-onset systolic murmur was noted on auscultation. Two-dimensional echocardiography revealed two small vegetations on the prosthetic valve. Empiric therapy consisting of amphotericin B, 5-flucytosine, vancomycin, and gentamicin was initiated. 3 blood cultures drawn on the day of admission were positive for Pseudomonas aeruginosa with the following antibiotic susceptibilities: gentamicin 8 micrograms per milliliter, tobramycin 2 micrograms per milliliter, piperacillin tazobactam 16 micrograms per milliliter, and ceftazidime 2 micrograms per milliliter. A presumptive diagnosis of PVE caused by Pseudomonas aeruginosa was made. Why was the finding of Pseudomonas expected in BCG? The prevalence of endocarditis caused by gram-negative organisms has increased significantly over the years, especially in IV drug users such as BCG and patients with prosthetic heart valves. Gram-negative organisms are responsible for about 15% to 20% of endocarditis cases in these populations. Most gram-negative endocarditis cases are caused by Pseudomonas species, Serratia marcescens, and Enterobacter species, although numerous other gram-negative organisms have been known to cause endocarditis. In narcotic addicts with gram-negative endocarditis, the tricuspid, aortic, and mitral valves are involved in 50%, 45%, and 40% of cases, respectively. The next question reads, how should BCG's gram-negative endocarditis be treated and monitored? The previous empirical antimicrobials should be discontinued because Pseudomonas aeruginosa has been cultured from BCG's blood. A bactericidal combination of antibiotics usually is required to provide in vivo synergy and to prevent resistant subpopulations from emerging during therapy. Endocarditis caused by Pseudomonas aeruginosa, as in BCG, should be treated for at least 6 weeks with a combination of an aminoglycoside and an anti-pseudomonal penicillin, such as piperacillin tazobactam, or cephalosporin, such as ceftazidime. The combination of an anti-pseudomonal penicillin and an aminoglycoside is synergistic in vitro and in the rabbit model of Pseudomonas aeruginosa endocarditis, and clinical experience has confirmed this finding in IV drug users. Combination therapy with high dosages of tobramycin or gentamicin, dosed at 8 mg per kilogram per day, has been associated with a significantly higher cure rate and lower mortality rate compared with an older, low-dose regimen, dosed at 2.5 to 5 mg per kilogram per day. BCG, therefore, should be treated with ceftazidime, dosed at 2 grams IV every 8 hours with concurrent high-dose tobramycin, dosed at 3 mg per kilogram IV every 8 hours. Aminoglycosides, that is tobramycin or gentamicin, should be dosed to produce peak and trough serum concentrations of 15 to 20 micrograms per milliliter and less than 2 micrograms per milliliter, respectively, to ensure maximum efficacy. Finally, the infected valve should be surgically excised for the reasons previously discussed. Other antibiotics including imipenem, cilastatin, meropenem, aztreonam, cefepime, and ciprofloxacin are active against many of the gram-negative organisms causing endocarditis. Clinical data regarding their use in the treatment of endocarditis are very limited, however. Ceftazidime, tazobactam, marketed as Zerbaxa, is a novel cephalosporin combination beta-lactamase inhibitor with enhanced activity against Pseudomonas and may be an alternative for treatment of multi-drug-resistant Pseudomonas infections. Its efficacy for the treatment of endocarditis is still being investigated. The next question reads, BCG's history, clinical presentation, and imaging studies are strongly suggestive of infective endocarditis. If his blood cultures had been negative after 48 hours of incubation, the working diagnosis would have been culture-negative endocarditis. So my question to you reads, what are the possible reasons for culture-negative endocarditis, and what measures should be taken to establish a microbiologic etiology? The proportion of patients with culture-negative endocarditis has diminished considerably, presumably as a result of improved microbiologic culture techniques. Negative blood cultures are present in only 5% to 7% of patients who meet strict criteria for the diagnosis of infective endocarditis and have not recently received antibiotics. The prior administration of antimicrobials is thought to account for most cases of culture-negative endocarditis. BCG's blood cultures may remain negative for several days to weeks if he has taken antibiotics recently. Slow-growing and fastidious organisms, such as gram-negative bacilli in the Haemophilus actinobacillus, Cardiobacterium, Eikenella, Kingella group, abbreviated as Hersake, Brucella, Coxiella, Chlamydiae, strict anaerobes, and fungi, should be pursued in culture-negative patients. This usually is accomplished by the use of special culture media or by obtaining appropriate serologic acute and convalescent titers. Blood cultures should be saved for at least 3 weeks to detect slow-growing organisms. Of note, previously NVS has been the cause of most of the cases of endocarditis diagnosed as culture-negative, initially because of its requirement for the addition of vitamin B6, that is pyridoxal hydrochloride, to the culture media for laboratory growth. However, laboratory identification is no longer a significant problem with current culture media and laboratory techniques. The next question reads, the causative organism remains unidentified. Recommend an antimicrobial regimen for the empiric treatment of BCG's presumed culture-negative endocarditis. In the hemodynamically stable patient, antibiotic therapy should be withheld until positive blood cultures are obtained. Based on BCG's clinical presentation and echocardiographic findings, empiric antibiotics should be initiated as soon as necessary cultures have been collected. Because Staphylococcus, often MRSA, and gram-negative bacilli account for most cases of endocarditis in the narcotic addict with a prosthetic heart valve, BCG should be started on a 4-drug regimen. Vancomycin targeting a trough of 15 to 20 micrograms per milliliter, gentamicin targeting a peak of 3 to 4 micrograms per milliliter, cefepime 2 grams IV every 8 hours, and rifampin 300 milligrams IV or orally every 8 hours. Because BCG may be experiencing a relapse caused by Candida albicans, the addition of amphotericin B and 5-flucytosine would be appropriate. Depending on the gram-negative pathogens common to the region and their anticipated susceptibilities, a third-generation cephalosporin, ceftriaxone or ceftazidime, or piperacillin tazobactam could be used. The combination of an aminoglycoside and piperacillin tazobactam also will provide coverage for enterococci. BCG's clinical status and the positive echocardiogram indicate that early surgical valve excision and replacement are necessary. Cultures obtained from the excised valve may allow for identification of the causative organism and subsequent alteration of his antimicrobial regimen depending on susceptibilities. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 243.